spine for flexion, extension, and if you consider side bending, lateral flexion, all of your flexion type motions are 45, rotations are 60 each direction. For this one, it's going to be kind of a similar concept as doing the goniometry from the front. This time, our external auditory meatus, aka the whole of the ear, is going to be our stationary, I keep wanting to say stationary arm for axis. It's going to be our axis. Our stationary is going to be perpendicular to the floor, which if he is sitting nice and upright should be parallel to the midline of the trunk. With that being said, if we're going into flexion, one of our deviations is trunk flexion, and if we're going into extension, one of our deviations is trunk extension. And then we are following parallel to the inferior line of the nose, basically. So some patients, their nose is a little off. I would just kind of think of it as following kind of like the midline as much as we can. But similar to doing it from the front, I'm gonna have to move my stationary arm to make sure, I keep saying stationary, axis, to be on where the axis is. Because it's the angle of the head and the nose to the floor that really tells me how much flexion extension is occurring. And because we're getting an upglide of each joint on one another, that is going to move. If I tried to have him flex and not move his cervical spine at all, then we're really just looking at the motion that's occurring in the upper cervical spine, and that's not a natural motion. In general, when it comes to the spine, I do look at more quality of especially when we're talking thoracolumbar. There's far more variance from individual to individual. So I'm really also wanting to look at quality of motion. That's going to give me more information to understand what's going on with the patient than the overall numbers. But getting these baseline measurements is important, especially when you're working in an insurance-based model, so you can demonstrate the improvement that you're making to get reimbursed. So I can, starting out, just place my hand on his back here, and can you go ahead and I want you to look down towards the ground. And at the very end of the motion there, I'm getting a little bit of motion through the cervical spine. Come on back up one more time. Slow the motion down for me just a little bit. Look down, 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 and right there is where I want you to stop. That's where I feel he's starting to get motion through his thoracic joints. And if I'm eyeballing it, I'm gonna say that's maybe a little bit beyond, but I'll just guesstimate at 45. And then let's go ahead and go into extension, come back to neutral, bring your shoulder blades back for me, and then go ahead and look up towards the ceiling. Any pain or discomfort there? Okay. I'm gonna guess more closer, oh, he went a little further that time. So I'm actually gonna guess 45 for both. Go into flexion one more time because I didn't do my overpressure for that one. Okay, right there. And then if I give overpressure, we're definitely getting that motion through there. So I'm gonna say firm and feel 45 for both. Come on back up, look down one. Actually, let me preset my GOMI. So I'm gonna go 45. I'm parallel to his trunk. Go ahead and come down. The hair's getting in the way, but I can do it. Go, 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 go. Right there, stop, come back up, ever so right there. And yeah, he's right about at 45. Come on back up. I'm gonna preset 45, actually 40 in the opposite direction. Okay, and then go ahead and look up towards the ceiling. Perfect, and he actually went a little bit further this time. So he's at 43. So maybe just a little bit more than normal. Going into flexion, just a little bit less going into extension. I'm not gonna overpressure the extension. I move my axis to stay in line. His long, beautiful hair is getting in the way, so I'm trying to look through it. Patients with long enough hair for the hair tie or the man bun, if they want to get it out of the way, great. If not, just do your best. But as I'm moving this, I need to make sure my stationary arm is not moving at all. That's really the biggest thing, okay?
Okay.
One.
Can you just repeat, sorry, the landmarks again?
External auditory meatus is going to be, yeah, I don't need to give him a wet willy to do it and palpate, but if he wants to do it to himself, that's fine. Perpendicular to the ground, which should be parallel to the thorax if he's sitting in good posture, is the stationary, and then the moving arm is parallel to the inferior line of the nose. If your patient's nose is offset up or down, then try and just treat it as if it wasn't. Okay. Any more questions?
Thinking in the future, say a patient has like a head wrap or a valve or something, would you just ask them to poke their ear?
That would be a good way to do it, because again, I don't want to be the one poking their ear, especially if there's something going on there. But yeah, if they had some sort of head trauma, have a wrap, I still need to be able to measure that. So yeah, I would just have them point. Great question. 1, 2, 3.